Second, second is the CCIH regional meeting that will be taking place in April 21 through 23 in the Philippines. So we seek participants from Asian countries who bring information, ideas, and views that will stimulate discussion and impact. The theme for this is Empowered to Lead, Advancing Health and Hope in a Changing World. If you have ideas for a presentation that will inspire dialogue, complete the submission form, which I think they'll drop a link into the chat here. Complete the submission form by October 24th, which is coming up fast. So that's a little heads up on what's coming up. And let me go ahead and get started on what we're here to talk about today, which is primary healthcare. And as a precursor to this, I really want to welcome you to this webinar. This has been a long time in coming. We started this project maybe a year and a half or close to 2 years ago. The work was in process through Momentum Country and Global Leadership, a USAID program where we were working under JPIGO. And that project, they had a particular emphasis on strengthening primary healthcare systems. And one of the questions that came up is, how are we actually contributing? How is the faith sector contributing to primary healthcare? And what would help the faith sector do that better? And that was a very encouraging conversation. But as we get ready to talk about what came out of that project, I'd like to step back and reflect for a minute that as Christians working, we're always looking to see how the church is connecting with people. And last night I was at a vestry meeting at our church, and the rector, as part of some long-range planning questions, asked us the question, what are you most proud of? What is the thing that you think that we as a church are doing that makes the greatest impact in the lives of people? And it was very encouraging to hear what people were talking about, from children's ministries to programs that meet the needs of people and populations in difficult times and places, to just simply the everyday ministry requirements of a growing and diverse population. So these were the kinds of things that were bubbling up, and it really made me reflect in preparing for today. What are we proud of? What are the things that we've done well? And frankly, I think some of us who are on this call were around during the early days of the primary healthcare movement, when it got a big push from the World Council of Churches and the World Health Organization that worked together to create the Alma Ata Declaration. And that really laid the foundation for the primary healthcare system that we have. We're going to hear some more about that today. And that's something where, as Christians, we can look back and have a bit of a healthy pride and sense of accomplishment that we helped to bring something about. But how have we done in the years since then, in the over 40 years now since that declaration? That's where we have to dig in and see, are we still sticking to the things that we said at the time should be there? How is it really going on a global scale? And then what do we know at the local level? And so that was the thing in our mind, is how, as Christians, are we able to use our gifts, use our talents, use our treasures to strengthen health and health systems. So back to the Momentum program, that's, we were very excited that USAID and our colleagues at JPIGO wanted to put that question to us. And so this was a chance for us to dig in and really clarify what we think the contribution of faith-based organizations is to this. And that started with taking a fresh look at literature and taking a deep look at what some key informants had to say. And that's a little bit of what we're going to talk about. And then we'll do a deep dive into Uganda as a intensive landscape analysis. So that's how we got here. That's a little bit of our thinking as we're getting ready for this. So I'd like to introduce who the three speakers are going to be. Well, I'm Doug Fountain. I'm Executive Director of CCIH, and I won't say more about myself with all of this, but I'm really excited that we've got two presentations and one discussant here. Presentation one will be from Dr. Allison Uark, who is a social epidemiologist, PhD from Hopkins, and assistant professor at Wheaton College since 2020. Prior to Wheaton, Dr. Uark spent her career as a public health researcher and consultant working with NGOs and FBOs, primarily in Africa, has expertise in behavioral HIV prevention, gender-based violence, impact of couple and family relationships on health. But Allison, on top of that, you are also the first staff member of CCIH back in the day, weren't you?
Long
So,
time ago.
so long time ago. That's great. That's great. Our second presentation is going to be from Janet Opio, who is a social development practitioner with a lot of years of experience working in health, social protection, governance, education, enterprise development with a strong commitment to capacity building. She's led high impact programs across East Africa, including serving as the country director at LifeNet International and chief of party for the Rwanda social marketing program of the Society for Family Health Rwanda, driving improvements in HIV prevention, maternal and child health, nutrition, and WASH. Janet was a terrific partner on this project as we really got into the intricacies of how the government works in Uganda and what are the data that we see in Uganda. So we're going to hear some more about that. So Janet, so glad to have you with us. And then we're going to be closed out in the discussion period by Peter Yaboa, who's the executive director of the Christian Health Association of Ghana. With over 2 decades of experience in faith-based and national health systems, he brings extensive expertise in health systems strengthening and development, social policy, health policy planning and financing, community-based primary health care. Uh, Gosh, Peter, you hold two postgraduate degrees in Master of Science in Health Policy Planning and Financing from the London School, and then a Master of Public Health from the Royal Tropical Institute in Amsterdam. And I know that you are very active in Ghana in helping think through at a very high level the policy issues, working with government and faith actors on primary health care. And that's one of the reasons we were excited that you would be able to join us today. So thank you for consenting to give time for that.
Grateful.
So with that in mind, I think I'll stop talking and turn it over to Allison. We'd love to hear what you have to say, and I'm going to keep the slides going, Allison. So just let me know when you want me to kick forward.
I
So
will.
I'll turn it over to you. Thanks.
So I'm presenting on the global landscape study. So briefly, the goals and methods of this study. We had 2 learning questions with the goal of addressing gaps in existing knowledge. There were also some sub-questions you can see in gray text on the slide. But question 1 was, in what ways are faith-based health facilities and organizations, FBHFOs, contributing to resilient primary healthcare systems? And we were using the definition of primary healthcare adopted by the World Health Organization and shown at the bottom of the slide. Question 2 was, how can we improve inclusive planning and coordination with FBHFOs towards national goals of improved access to timely, high-quality primary healthcare services? So the methods of this study, there was a literature review carried out by USAID, Momentum Knowledge Accelerators, MacLab, and they reviewed peer-reviewed research from 2015 and later from low and middle income countries, identified 27 articles, and then also included some gray literature, not part of the peer-reviewed literature. And then I carried out the second phase, which was key informant interviews. We did 10 interviews with 11 global experts with knowledge of FBHFOs and primary healthcare. Okay, we can go to the next slide. So there were 5 themes which emerged from this study. I'll cover each of them in turn. So the first is really just a brief timeline of FBHFO's historic role in establishing global primary health care. So the Christian Medical Commission was established in 1968 under the World Council of Churches and called for comprehensive health care and equity, a move beyond curative care, and involvement of lay people and professionals in the work of healing. And of course, this emphasis was coming out of decades of work that Christians in the church had already been involved in healthcare and primary healthcare globally. And really noted the need
National
for
tenders is still running, right?
community-based care beyond just facility-based care. And so in the early 1970s, the Christian Medical Commission brought to the attention of the World Health Organization community-based projects focused on primary health care, such as the Comprehensive Rural Development Program in Jamkhed, India. So the WHO began to acknowledge the importance of this community involvement in meeting basic health needs worldwide and reorient from prioritizing top-down national health systems to emphasizing bottom-up approaches based on community involvement. In 1975, established primary healthcare program area. And of course, 1978 was the year of the Alma Ata meeting and historic declaration on primary healthcare. So what is the legacy today? In a nutshell, there was a feeling in the literature and among key informants that momentum has really waned, and that today collaboration for primary healthcare between FBHFOs, governments, and other partners remains variable. Okay, second theme, FBHFOs provide a breadth of primary healthcare services. So they work in health facilities and communities, both types of work going on. They are felt to be making particular contributions in the areas of HIV/AIDS, maternal and child health, family planning, and epidemic response. And they often pioneer new approaches, which are then adopted more broadly. So they can work innovatively, they can work nimbly, and often just have real contributions in new approaches. So there are examples of this in the report, if you want to read about some examples. And in many countries, they also disproportionately train the healthcare workforce. So India is a good example of this. Um, However, there was a feeling among key informants that primary healthcare is shifting from community-based care to more facility-based care, and that perhaps something is being lost there. Okay, next slide. So third theme, FBHFOs have a reputation for providing quality whole person care and for serving underserved and remote populations. So they bring distinctive values and commitments, including a people-centered approach. They also bring a distinctive sense of mission and a commitment to the last mile, which is a term often used to referring to serving the needs and reaching the most underserved and remote populations. They have a mandate to provide spiritual and emotional care, so going beyond healthcare to caring for the whole person. And they also can make long-term commitments. So they're not as dependent on grant funding cycles and can stay in situations of conflict and crisis when other NGOs and health facilities may be closing their doors. So an example of this was during the COVID-19 pandemic. All right, the fourth theme has to do with FBHFOs providing a substantial proportion of healthcare in many settings. So previous work and research has attempted to quantify this. It's hard to do, hard to quantify it, and estimates vary, but a very wide range is that from 20 to 70% of healthcare globally is provided by FBHFOs. So, for example, in India, obviously a huge population, Christian hospitals are second only to the government in the number of hospital beds provided. However, FBHFOs are not always well integrated into national health systems and policymaking. So even when it comes to knowing what their contribution is, they're often not well integrated into data reporting systems. One KI noted that FBHFOs should be seen as a complex system operating in politics, the private sector, and the health sector. So there's not just one type of FBHFO or one model of care, and they may be more or less distinct from other NGOs or providers. As I've already noted, there's real gaps in knowledge regarding the scope and scale of FBHFOs, and also how they're integrated into public and private partnerships with governments. And of course, we're in an era of declining funding. So in some cases, FBHFOs are attempting but struggling to integrate into government funding systems and receive government support. Okay, and the last slide. So, in terms of looking forward, the fifth theme had to do with how FBHFOs can be part of universal healthcare systems in an era of UHC and help expand or revitalize primary healthcare. So, some KIs were concerned that primary healthcare has eroded with time, the vision of primary healthcare and the practice, and called for FBHFOs to restore a strong, comprehensive vision of primary healthcare, not just primary care. So there's this issue that primary healthcare is sometimes used interchangeably with the concept of primary care delivered within health facilities, so that the concepts of primary healthcare becomes conflated with facility-based care. So KIs also called for churches to become more involved in primary health care. One KI said more churches need to become involved in health promotion and community work. So that community-based vision of primary health care, not just facility professionally driven, carried out by a health professional form of primary care. KIs also expressed concerns about integrating FBHFO services into payment structures. So there's a need for more sustainable funding for FBHFOs, as their funding can be donation dependent and fragile. So how can they become integrated into universal healthcare schemes, such as through national insurance and UHC systems? So finally, 3 recommendations emerged from this work. First, to further study the extent of government inclusion of FBHFOs. So we're going to see an excellent case study of Uganda, but we need more case studies like this. Second, to establish cross-national roll-up of FBHFO data and further include data in national planning and resource allocation. And finally, is there a need to examine FBHFO priorities, ask if there's been a shift away from community-based services and what has been lost? So ask the question, are FBHFOs prioritizing facility-based care, community-based services, or both, and what should priorities be? Thank you so much.
Thank you, Allison. That was fantastic. And as we were progressing through the report, and you were sharing these results, I was really struck by this because we seem to think for some reason that the primary care becomes an either or. It's either facility or it's community based when it can be seen as a both and that seems to have been the original vision. And the question is, have we lost some of that, or the community focus has eroded somewhat? That's a really interesting area to discuss. Thank you for sharing that. I think you're right. We're now going to turn to the Uganda example and see what that looks like from Janet. So Janet, I'm going to kick over to you now.
Thank you very much, Doug, and thank you, Alison, for setting the foundation. I am going to focus on the case study for Uganda, the faith-based health facilities in Uganda, and give you some insights into what we gathered from the key informants interviews. Next slide, please, Doug. Okay. The faith-based facilities in Uganda have a very long history. In fact, the first health facilities were established in Uganda in 1897 by the Anglican Church through the Church Mission Society. We had Mengo Hospital, and I think 2 years later, in 1897, the Catholics also established a hospital, a health facility in Rubaga in Kampala. So we have a long history of the faith-based health facilities being established as by the churches and by the church through the Church Mission Society as part of the integral ministry, in fact. And since the period that I have mentioned, there's been a progressive increase in the establishment of health facilities by the Anglican Church and the Catholic Church, and later on the Muslims established facilities, and the Orthodox Church as well has established a number of facilities. So in other words, the health facilities in the faith-based sector have been an integral part of Uganda's health systems, and they are considered private but not for profit, while there is the public side which is purely government. But the faith-based health facilities come in to complement the work that the government does, in especially reaching the rural poor, very vulnerable communities, and sometimes communities which are very, very found in remote places that have got very limited access to health services. So the faith-based sector bridges the gap in terms of increasing access to services for the communities. And so this case study sought to find out really to what extent really the faith-based facilities are contributing to Uganda's health system. And we had two questions. One question was, how are faith-based health facilities contributing to a resilience primary health care system? How can planning and coordination of this faith-based organization be strengthened to advance national primary health care goals? And how can the primary health services, how are they delivered, and how well are the faith-based sector integrated into the primary health care planning? And as I said earlier on, the faith-based sector has been part and parcel of the Uganda's health system, grouped into or coordinated through what we call the medical bureaus. So, for instance, the Anglican Church has the Uganda Protestant Medical Bureau, which coordinates health facilities that are established by the Anglican Church and the Adventist. And we have the Catholic Medical Bureau, which coordinates all the facilities in the country that are established through the Catholic Church. And we have the Orthodox Medical Bureau and the Muslim medical bureaus. And all of these come very strongly to support the facilities that are established through their various religious affiliations. And in addition to that, actually, we also have the faith-based sector contributing very much to workforce training through the nursing schools, through the universities. And the faith-based sector also has a supply chain aspect which supports the commodity side of their operations, like the joint medical stores, which was jointly established through collaboration of the Uganda Catholic Medical Bureau, the Uganda Protestant Medical Bureau, and the Orthodox Medical Bureau. So you can see that the faith-based sector in Uganda is an integral part really of the health system, and it is well respected. Next slide, please. The purpose of the landscape, I think is the next slide, Doug. Yes, thank you. The case study for the Ugandan context took a two-pronged approach. The first was to look at the DHIS2 data through the database through which all the health facilities report their health information. And that was complemented by key informants interviews at national level as well as district level. And we had 5 districts that were selected. At national level, we had interviews with the Ministry of Health, the chiefs of the bureaus, the medical bureaus that I mentioned earlier on. We also had interviews with the joint medical stores and other national level actors. And then down at the regional levels, we had interviews with the district health officers for the public sector, but who also coordinated the faith-based health facilities. We had interviews with diocesan health coordinators who coordinate health services for the churches. And we also had, at facility level, we had interviews with the health facility in charges or medical directors, depending on the level of care. So these are some of the major results that came out of these 2 studies. From the DHIS2, we established the scope and the contribution of the faith-based health facilities in Uganda. And for instance, currently, we had 735 health facilities across the medical bureaus that I mentioned, the faith-based medical bureaus, and 62 of those hospitals and 673 health facilities at different levels, providing quality of care to the rural communities that are disadvantaged or lack access to health services. So that was a critical finding, and as you can see from the map of Uganda, that in every district there was a good contribution of the faith-based sector in primary health care for the period 2020 to 2023. That was the data that we extracted from the DHIS2, and those are the findings and the evidence that the faith-based sector is contributing to primary health care services in the country. The second one is financing and sustainability. The faith-based sector in Uganda from 2003 have been receiving what we call conditional grants for primary health care, specifically specific services that they provide to the communities, and the government provides financing for that, either directly through commodities, but also directly through the district health facilities to support the activities, the outreaches in services that are outpatient related and community outreaches. And so that is the contribution that the government is giving, and it's been progressive over the years. It's been increasing over the years, although still that is not adequate to cover the operational costs of the health facilities. But it is something. Then the second way that the health facilities in the faith-based sector sustain their services is through user fees, because as I said earlier on, the conditional grants are non-wage, and they cannot cover all the costs of operation. Things like staff salaries, infrastructure development, etc., are not covered through the conditional grants. And so health facilities have to charge what we call user fees to cover the cost of operations. And remember, these are facilities that are based in the rural areas. They support and provide services to the underserved, and most of these sometimes cannot even afford the user fees. And the key informants interviews with the health facilities revealed that actually the user fees is seen as an access barrier, because not everybody can afford to pay user fees to access these services. In some instances, actually, patients run away without paying the user fees, or and the facilities have to struggle to make ends meet. The third way that the facilities sustain their financing is through what we call the results-based financing, originally introduced by the World Bank in around 2000, early 2000s, and the financing model helped the facilities to support their operational costs, because it was more flexible. It offered them the flexibility to pay salaries out of that, to do some infrastructure development, renovations, and etc. But that is not there anymore, although it helped when it was there. Another key result of this case study for Uganda was we identified from the key informants interviews the strength that the faith-based facilities contribute or bring to the health system. One of them is the compassionate care. And as I said, these facilities were largely established as part of the integral ministry that the church in the communities, responding to the needs and the healthcare needs of the communities specifically. So they demonstrated the love of Christ by providing care and compassion to the suffering. But also too, the faith-based sector is seen as one that is reaching out to service the very poor and reaching the remotest areas and reaching the very, very vulnerable communities that the public sector is not able to reach. And that is the complementarity that the faith-based sector in Uganda provides to the government or the public sector side of the health system. There are some challenges in this faith-based sector health system. One of them is shortage of staffing. Because of the inadequate financial capacity due to the limited conditional grants and the user fees insufficient, they are not able to attract adequate staffing because they can't pay them. The public sector in Uganda pays a lot better than the faith-based sector, and so there is continuous turnover of staffing from the faith-based sector running to the public sector where the terms are better. And so that is a critical challenge that the faith-based sector is facing at the moment in terms of staffing shortages. And two is the data quality. As I said earlier on, that one of our approaches was looking at the DHIS2, and through digging into that, we've discovered the data quality challenges and in all dimensions of data quality, in fact, in some incomplete information, timeliness in terms of reporting, the accuracy, the integrity of the data sometimes is questionable. And although by and large, most of the health facilities that are faith-based try to report into the DHIS2, nevertheless, there are data quality challenges that need to be addressed, because if the data is not clean, if it's not reliable, and it has no integrity, it affects the quality of decision-making and planning. Another challenge is the over-reliance on external and donor-driven models. I talked about the results-based financing, the RBF, which was introduced several years ago. It worked well. It offered flexible financing for the activities, but it was not institutionalized because it focused on certain services, not all the services within the health facilities. So that is a challenge, because when it was available, the financing offered great opportunities that increased patient volumes and improved efficiency and effectiveness in those facilities. But once the RBF stopped, then services dropped because the system or the model was not entrenched or mainstreamed within the facilities. And next, please. Some key takeaways from this case study. One is faith-based facilities are indispensable to Uganda's primary health care system. From the numbers that I shared earlier on, 735, more than that, health facilities in Uganda, and making a great contribution to the services. We have over 900 million outpatient visits annually from 2020 to 2023 that we saw, and the extent of services where government is not able to reach the communities. So the contribution of the health faith-based sector is very, very complementary to the public health sector, and it is regarded as part of the Uganda's health system. The other takeaway is the government partnerships work, but they remain underfunded. As I said earlier on, they depend on the conditional grants, which are very critical, but they're inadequate because the conditional grants are non-wage. They don't cover renovations or infrastructure development. They only focus on facilitating primary healthcare services and outreaches in the communities. They don't even cover staffing. So it has been progressive, but it is inadequate to sustainably finance the operations of the facilities. And then the second thing also, as I said, RBF, the results-based financing, which was introduced, it stopped, and it was not institutionalized. And therefore, once it stopped, it was not possible to sustain the model. The third one is data and staffing are bottlenecks, as I said earlier on. Data quality issues are still a problem, staffing levels are still inadequate, and so improving the DHIS2 is a key area that needs to be reinforced, and workforce shortages also need to be looked into if we are to scale up primary health care in Uganda. And finally, trust and community reach is a strength, actually. As I said, the faith-based sector has a deep reputation in Uganda for providing compassionate care, for being committed to their patients, and for reaching the rural areas or underserved communities that the public sector is not able to. So they have a great contribution in helping the country to achieve universal health coverage. So Uganda's case study shows that faith-based facilities they're not just historic players, but they are current and future pillars of primary health care in Uganda, and therefore strengthening their financing, the data quality, the staffing, while sustaining government partnership is very, very important in achieving universal health coverage. Thank you very much.
Thank you, Janet. That was fantastic, and such a insightful set of things that we learned about the policy and the practical side of faith-based primary healthcare in Uganda. So a couple of things. I want to do one small clarification. Before we turn to Peter, reminder, please, if you've got questions, go ahead and share them in the comments. We'll capture those questions and make sure we've got plenty of time. We should have about a half hour for discussion. Go back to one thing, Janet, on this slide with the data in the different districts. As I recall, this was data on percent of patients. I'm sorry, percent of service episodes, not percent of patient, percent of service episodes delivered through faith-based organizations in each of these districts. So normally when we talk about these things, we talk about percent of facilities. And the problem is facilities masks the deeper issue, which is how much patient volume is going through them. So if the DHIS2 is underreporting service episodes, you're going to think that there's less being delivered in those facilities. So just wanted to add that. Did I have that right from what we looked at?
Yes, you're right, Doug. Thank you.
Great, thanks. Okay, so please, if you've got questions, go ahead and pop them in and we'll track them. I would love to turn it now to Peter, and I'm going to stop sharing and give Peter a chance to reflect on this from Ghana, continental, and global perspectives. Maybe I just increased your scope of comments, Peter. So please, over to you.
Yes, many thanks, Doug, and thanks to Janet and Alison for that insightful presentation. It is very clear that the situation and the challenges set a context for our common discussion. I mean, when the issues that are coming out are something very common to faith-based actors, and I could relate Ghana's experience to that. The theme or the topic for this webinar is very clear, that building resilient health systems, the untapped potentials of FBO. And for a quick reflection, it shows that FBOs have assets, and the assets are many and varied, which have been validated by presenters. We have deep community roots and trust. We are trusted. We have the infrastructure, the service delivery experience, serving the unreached, underserved, and poorly served. And our strengths in holistic care models, physical, mental, social, and spiritual well-being is very clear. And we are highly trusted and respected. And that is heartwarming. It is also very clear that despite all our assets and being recognized as integral actors into the public health systems and the rest, faith-based actors are underrepresented, underfunded, and underutilized. And that is where the untapped potentials come in. But I think if we are to address this common experience across board, I'll use Ghana's experience, that I think we need a paradigm shift. We need to transition from being implementers of PHC programs. PHC is a vital instrument for achieving universal health coverage, and all sub-Saharan African countries have signed on to it. We need transition from implementers to decision makers, or possibly committed providers to strategic partners in engaging government. It will appear that government set up an overall framework within which we have to. And as people rooted in community health services, we are bridges and brokers in engagement with government. And I saw two key issues come in play. One, if we are to address the challenges that have been enumerated in terms of funding, getting sustainable funding for PHC, human resource or health workforce issues and data aspects, and for faith-based actors to be deliberately and properly included in funding allocations and the rest, we need one, policy leadership, health policy leadership. And I'll explain how we can really embrace policy leadership. And secondly, strategic partnerships to influence one, health policy agenda, PHC priority setting, as far as funding allocations in our sector. In our part of the world, or in Ghana, CHAG is intimately involved with the government, and our relationship is guided by an MOU. So the need to formalize the partnership is very important. And formalizing partnership will require initiative from us, and I'm happy most actors are part of it. We need to set an MOU that recognizes faith-based actors as integral part of it, not only in name, but being part of joint planning, working group committees, budgeting, and allocation is very important. Beyond being recognized as such, it helps us to legitimize our presence. Nonetheless, we also need that software of policy engagement, advocacy, negotiations, and being present, and even taking an initiative to invite them into our meetings and fora. And so if PHC is to be the instrument for our evangelization and for our mission, definitely we need to engage government that holds the national purse to give us our fair share. So in Ghana, CHAG receives salaries, receive other benefits. It is not all the way perfect, but at least we make sure that we are able to negotiate with government to let them be aware that we represent the people that need services. We complement them, we don't compete with them. And beyond that, we are also fairly represented in the National Health Management Information System, because the game is about evidence and data. Faith-based actors should have that sense of entitlement, but then intentional capacity to engage key actors and use evidence and data to demonstrate, one, our contributions, our capacities, our gaps as basis for, of course, asking government to include us in the funding architecture. We are having a common challenge of our national health insurance scheme that, of course, CHAG pioneered and piloted, that only incentivizes or pays for facility-based care. And so the incentive to go on outreach is really a challenge. And for CHAG, we only rely very much on development partner support to go out, to demonstrate, to provide a primary healthcare in the rate, which is definitely not enough. And I call it a mission drift. And so the need to address the funding gaps and ensure that we have sustainable funding will be very much critical in the way we promote and project primary healthcare as a vital instrument for community, engagement and participation in the entire health architecture. I think that for now, we need to be aware that if we represent, or we are the anchor of the community, we should be able to intentionally and actively engage development partners, government, for what I describe as blended funding arrangements. But government has the overall ownership. Of course, PHC is government-led, but country-owned. And so our ability to be part of the policy space and actively engage and negotiate for our fair share of funding will promote resilience, equity, and community-based impact. I think we have a rare opportunity at this point in time to ensure that our partnership with government becomes very much intentional. And one of the ways that CHAD has been able to influence government is to demonstrate service delivery innovations. For instance, recently we piloted Safe Care Quality Improvement Program, and after piloting it, we were able to pitch it to government in a co-creation manner, and government has now adopted that quality instrument, and Ghana has adopted it, and then also claim it application with the National Insurance Scheme that ensures prompt submission of claims, and then NCD projects and programs. We do all this to influence PHC agenda setting within that particular space because we are aware of the policy inertia, and government politicians usually have a short duration in office. Bureaucrats and technocrats sometimes need assistance to set agenda that is more impactful and to make sure that they are well included for purposes of attribution and contribution. And so we have a rare opportunity to harness the massive potentials we have as faith-based actors, our reach, our cloud, our gravitas, our social capital, our church leaders have what I describe as one of the largest social capital in our health system. They are vital for addressing, for promoting demand, for ensuring that uptake of community-based health services are there, even engaging government to make sure that we are onboarded. And I think that if we are able to recognize our distinctive capacity, our role, our prospects and potentials, and ensure that engaging government requires both hardware of formal relationships and software of active and intentional engagement to make sure that we rein them in to recognize us as partners and not competitors, as co-creators. I think that we'll be able to promote primary healthcare as an integral part of our service delivery portfolio, and by so doing, promote that co-ownership and represent the community that recognize us as trusted agents and champions of their health needs. On the whole, I think that our potentials need to be tapped, and very soon we will definitely experience how government rather require us to demonstrate impact onto the larger community that we serve and save. I think this is an opportunity, and thanks for the two presenters for pitching vital ingredients and key instruments required to ensure that primary healthcare becomes the instrument for achieving equitable access to quality, attainable healthcare services to the underserved, poorly served, and unserved populations that are entrusted to us. Thank you.
Thank you, Peter. I really appreciate the depth of your commitment to collegial relationships and building a cooperative environment between faith and government, private sector. I think that is so helpful, and I'm reminded as you were commenting on the community is not always there because primary healthcare pays for work done in health facilities. Makes me think about the question, the thing, what gets measured gets done. And so maybe I just have one quick question for you about metrics. How do you define success? How do you measure success in this? If you have a quick comment on that, then I want to go. We've got some very exciting questions for Janet and Allison, but sitting at a high policy level, how do you measure success in primary healthcare in a few words?
Yeah, absolutely. I think success in primary healthcare, to me, is just about the quality of collaboration with our partners, especially government, our ability to integrate into the larger health system, and most importantly, service delivery improvement in terms of comprehensive health services to the community that we serve, and most importantly, that community level impact that is very vital. And by this, I mean that we need to develop governance and coordination metrics. And the question is how many faith-based actors have formal relationship with government? How do we participate actively in planning and policy development? Are we influencing, or are we involved in joint strategy, alignment? We need to align what we do with government so that we will be active actors and partners. I think we also need to develop service delivery metrics. It is about PHC service coverage in terms of broad reach, who are being included. I think health workforce metrics is also very important. How many of our health workers are trained, are prepared, are capacitated to provide PHC services? And of course, data reporting accountability, data integration, the use of it. Janet mentioned it very well. I mean, comprehensiveness, timeliness, accuracy promotes accountability and use of resources. And of course, financial and sustainability metrics. Financing is indispensable. It is a key ingredient. And so as faith-based actors, I think the risk of overemphasis on being non-profit might probably blur us from adopting efficient and effective measures of managing the resources that we have. At the risk of overemphasis, I think we also need to look at how do we optimize and manage our resources. And finally, equity, inclusion, and community impact metrics are very important. At the end of the day, we want to ensure that the underserved, the mothers, children, the marginalized, neglected are all involved in this. I think certainly, if we are to look at these metrics are described as success indicators, then certainly as faith-based actors, we will be pitching our role as champions and advocates of Christ healing ministry, targeting underserved and people that need our services most. I think that will be my snappy comments on the metrics of PHC, success, what I describe as success. Definitely, it's about our alignment, integration, equity, and mutual accountability that all of us are supposed to project. Thank you.
Well, you've outlined a terrific agenda for that for us to take up globally, is how to measure this. And Allison, that actually relates to a couple of questions that have come in for you, and I'm going to put them together. One is a question about a comment about research and IPC are critical elements of resilient primary health care. How can we improve research among FBOs that is identifying funding sources, building capacity, and mentorship? So how do we improve research? But related to that is another question: how can we get stronger leadership or engagement from the church? And do we know anything about whether church engagement strengthens primary health care?
So both questions about research and just the data available. And I'm thinking back through interviews with key informants and whether this came up. I'm not sure it did in a major way. I think the overarching comment here is just a need for more information, and also the point that often organizations that are most actively providing services and working on the ground just don't have the resources to do the kind of data collection and documentation that they would like to. I appreciated Peter's point that even community-based work is often not paid for or incentivized. So I think money is driving a lot of this. The first specific area of research you mentioned, sorry, I just lost it, was remind me what the first type of research you mentioned was.
From the comment, it was improve research among FBOs, identifying funding sources, building capacity, and mentorship. But the related question was about the church and the role of the church.
Yeah. Yeah, and is there research to really document how the church adds added value? I don't think there is in the peer-reviewed research, and even in key informant interviews. I mean, many of them were speaking from, deep personal experience, bringing up case studies. But I would just point out, yeah, the lack of research and documentation, even the initial phase of this study that I didn't conduct, but that was doing a literature review, only found 27 studies in total to address this question. So I think, yeah, it's just a constant need to better document what faith-based actors are doing and get it into research and other accessible forms of information.
I find that so fascinating because, in the community space, in community health, there's a lot of research about the role of church engagement in community development, community strengthening, and community health. It's just when you get to primary health and you're treating health conditions or addressing health concerns, the research on the church linkage gets a little bit more tenuous.
Yeah, it's not being funded, not being supported, and HFOs have the resources to do it.
Janet, that also gets to a question that came to you. One of the questions, I think when you talked about the different medical bureaus, and you You spoke about Catholics and Protestants, Orthodox, I would include Muslims, uh, working together towards common agendas. The question is, how's that relationship going? How's that working? I mean, these are, in some cases, very large and complex church structures, and they all have an interest in health. How are their relationships across the bureaus?
Thank you very much. The relationship in the bureaus is actually very structured because, as I said, that the faith-based health sector is an integral part of Uganda's health system, and because they have so many health facilities, as I indicated, over 700, and they reach the rural areas, the underserved communities, the government itself recognizes their contribution and their role. And so one of the things that was important for the bureaus to actually have a collective voice in order to engage with the government even better was to form the bureaus. The Catholics have their bureau, the Anglicans and the Adventists have the Protestant Medical Bureau, which is a good collaboration between the Anglican Church and the Adventists, as well as the evangelical. The health facilities that are started by the evangelical churches are all under the Protestant Medical Bureau and coordinated through the system. But the bureaus do have a place in the highest policy making organ of the health sector, where they sit with the government. And for that reason, they have to have strong coordination, and they do have, because they need to go to the government in those policy processes, the policy working group at the ministerial level, as one voice. And so for them to be able to do that, one of the things they did was to agree together, realizing that the government does have, for instance, a supply chain agent, which is different and serving the public sector, and yet the private sector as well as the faith-based sector didn't have easy access to medicines and commodities. So they formed with the support of USAID back then, they created the joint medical stores as their supply chain agents. And the Orthodox, the Anglicans, and the Catholics did, in that collaboration, form the joint medical stores, which has become a very big entity, which is serving the faith sector, but also the private sector. And to some extent, they have been able to help the facilities to have easy access. So coordination, they are well structured. They have good structures and good representation up to the policy level. So they sit as a bureau and decide what they would like. And I think part of the findings of this study, when I talked to some of the bureau chiefs in the Catholic Medical Bureau and the Protestant Medical Bureau, was they're beginning to see how can they sit together and actually engage with the government to demand for an increase in the conditional grants that they currently receive. So there is good coordination and good collaboration.
There's even more questions that are coming in, and this relates to things that we are hearing outside of Uganda and generally towards the faith sector about the role of these medical bureaus or Christian health associations like what Peter runs. A couple of questions have come in related to government's relationship with them. Is there a part of the Ministry of Health that maybe a unit or a department that is specifically tasked to work with faith-based organizations? And maybe you can comment about the high-level policy task force that they all sit on as well.
Thank you. First of all, the health sector, like any other sector in Uganda, have got what they call the technical working groups. And the technical working groups are a collaboration of the government, the public sector, the private sector, which includes the faith-based sector. So there is a framework already in place, which is instituted by government to cause collaboration, to cause cooperation. And the faith-based sectors, the chiefs of the bureaus sit in those technical working groups, which is a working group for the entire sector, planning for the sector. And then at the highest level, at the ministry, the chiefs of the bureaus are represented in that platform. Uganda Protestant Medical Bureau and all those other bureaus that I mentioned, they sit at the highest policy. They have been able to find themselves in that space because of a collective voice.
Which is remarkable. And
Yeah.
I don't know, when I look across, Africa has more strong, robust Christian health associations than most other continents and that we interact with. But I don't know how common that is. I know in Uganda it's very strong, in Ghana it's very strong, but I hear in other countries the relationships are not so strong. But that seems fundamental to planning. Maybe one more thing, Janet, maybe if you could think of a specific population or a specific topic area like respectful maternity care. Take that as an example. There was a question that came about respectful maternity care. Would
I saw
those,
that.
yeah, so maybe comment about the question about that population and how it relates to these bureaus, broad-based coordination, and the role of faith actors generally in that.
Thank you. The question on respectful maternity care is one of the advantages that the bureaus or the facilities that are faith-based bring in the sector because of their compassionate care. As I said, they were moved by compassion and integral ministry to have compassion on sick people, to care for those who are suffering. That is the main objective why the faith-based health facilities were established. And therefore, because of that foundation, the approach is respect the patients, be merciful, be gracious, be kind, be compassionate when you're delivering health services to the poor, to the vulnerable communities. So one of the things that the faith-based facilities are known for is the respectful maternity care for mothers. They respect, they have compassion, they are kind to their patients, which is different. And that is, I think, something for us that distinguishes a faith-based health facility in a great way compared to the public health facility.
Really helpful.
Yeah.
Broad-based, a lot of the questions, several of the questions here, but even throughout this whole project, the questions come up about sustainability, and there are a few questions, Peter, that were tagged to you about the breadth of the work that FBOs are involved in, and they have a reputation for excellent services, but the challenge is maintaining access to them, especially when they're having to fight for their own survival. That issue about sustainability of faith-based health facilities is a real concern. You spoke about it a little bit when you spoke about the health insurance programs within Ghana that you pioneered, but also broadly throughout the region. What are you seeing that gives you hope or gives you concern about faith-based sustainability?
Yeah, very well. I think when it comes to sustainability, it is an existential issue, and it is also aspirational, regardless of what it is an existential issue because the secularization, the increasing prominence of government and secular in there is a threat to that moral, ethically driven health services and the rest. And so, and it is also aspirational because faith-based actors have been, by our history and support, we have depended mostly on development partners throughout in the design and delivery of programs and projects and the rest. And so it is a shared challenge, along all of us. But it is also an opportunity for us to see how we can really assess our strengths, our ability to really explore opportunities that exist. And the fact that governments would continue to exist and government holds the national pace would also mean, I spoke of blended financing, would also mean that we have to have some innovative ways, creative ways of actively engaging government in policy and practice, harnessing our social capital, our strength, using church leadership for them to recognize us as integral part. And that recognition is not only by name, but also to be involved in budgeting, in allocation of resources, and secondly, also to engage development partners abroad. Often, development partners with best of intentions route funding through government with the hope that it will trickle down to faith-based actors. I think that reality, that narrative, we need to help development partners to change that narrative very well. We saw in the COVID response actions how faith-based actors were the first responders, and our interventions were aided mostly by direct funding support by development partners. And so it makes us complementary partners. The risk always in being a supplicant and a beggar to government is that you may even lose your identity. You risk being fully assimilated. Remember, let's distinguish between integration and assimilation. Integration is very important because you maintain your identity, you're able to influence policy with your ethos and values and principles. Assimilation is a risk and a threat where you lose your identity and values and the rest. I think that we should engage government to get our fair share of the national marketing. We should also engage development partners to get this done. We should also explore feasible local opportunities. Private philanthropy is also very needed. Many years ago, Chag observed that government policies were rather serving as hindrance and barriers to services. We pioneered and piloted community-based health insurance scheme. And when it became proof of concept, the government took it to become what we now call as National Health Insurance Scheme. I think that, and all of us now are depending on that, on that scheme to fund services. We are trying to influence service portfolios so that they will also be funding certain community-based health services, engaging the political actors all over. And I think that one way is to engage both technocrats and bureaucrats on the technical side and politicians to change their manifesto. And so I'm looking at broad-based exploration of sources of funding so that we don't become dependent and too vulnerable to the mood swings of key funders. We are aware of sudden change of development funding architecture. And so government is a source, development partners source, even the church leadership. It is time for the church leaders to be actively involved in funding, financing, feasible community-based interventions, using our spaces, exploring efficient source and the rest. And I think that it is a matter of existential threat, but also an opportunity for us to change the architecture and the way we design, deliver services, and the way we source funding to promote our common mandate. That is what I'll say. Thanks.
Wonderful. I'm going to give you all just a one sentence close here. If you maybe something that gives you hope, something out of this conversation that you want to share as we prepare to wrap up. We've had a lot of terrific conversation. We've talked about the initial architecture of primary care and the role that community and health facilities were supposed to play together, but community-based gets underfunded or not funded or not integrated at all. Sometimes for a variety of reasons. There is a lot of experience with broad policy coordination, but it is uneven perhaps across different countries. And we have to really commit to a collaborative approach between the faith sector and the governments to see success in that. Faith-based organizations have a tremendous reputation for quality and innovation. It's exciting to see what they do, even in moments of scarcity. This is what the faith-based movements have been built upon, was not having adequate resources and not having enough, but figuring out what to do. And that is part of the legacy that I think makes us strong. There is a need to double down on data and research. We know that some of the gaps that exist in the HIS2 will cripple the ability of faith-based to advocate for itself. So I hope that we can see better streams there. And then stronger research on the connection between primary care and the church. What is the role of the church in strengthening that? How does primary care help expand the purpose and mission of the church as well? So these are areas to really explore that are coming out of this. And I'm very excited by the whole nature of the conversations that have happened here. I'll go to each of you, starting with Allison. Any final one sentence or two sentence takeaway, something to give us hope as we move out of here today?
I just want to say I've really enjoyed seeing the comments in the chats, and it's just reminded me of just the tremendous human resources that the church and FBHFOs bring. I mean, the people and the commitment and the passion, and I've just been reminded of that seeing comments. So I think, yeah, as you highlighted, big challenges with funding and scarcity and lack of data, but I think the church and God's people have always just persisted in the face of great challenges. So I expect to see that continue.
Thanks, Allison. Janet?
Yeah, thank you, Doug. I think in addition to what Alison has said, the church will always be there to fulfill its mandate of spiritual and meeting community needs. I think the advantage that the church in Uganda, or the faith-based sector has in Uganda, is a government that is responsive. And even though the grants, the conditional grants are still very small, but there's progression. We can see an upward trend. I think the challenge now is for the bureaus to think about financing and sustainability of the good work that is already happening in reaching the underserved communities, God's people, and also for the bureaus to form a stronger voice and advocate and lobby for increased subvention to further the work of the church
Wonderful.
and the communities. Thank you.
Yeah, great. Okay, and Peter, last comments.
Thanks. I would like to look inward. Our assets give me hope. Our unity in diversity means that we should shift from scarcity to abundance mindset. We have an opportunity to shape the architecture of primary healthcare, and the health and healing ministry of our Lord Jesus Christ would empower us to do the needful. But in all, we need leadership and partnership to make sure that we harness and explore all innovative sources potentially from all areas, so that we will address the issue of funding, comprehensive health service delivery, and make sure that we build a resilient, sustainable, responsive faith-based systems capable of meeting the health needs, aspirations, and values of the people we serve. It's a pleasure, and we have the capacity. God bless us and make us great. Thanks.
Amen to that. Thank you, everybody. Really appreciate Allison, Janet, and Peter. And let me pray for us as we close today. Lord God, I thank you for this time that we've had, and thank you for the session. Thank you for all of the wisdom shared here and the creative comments and questions and discussion. Lord, we hand this back to you and pray that you inspire us to do things coming out of this that you would have us do. Thank you. In Jesus' name we pray. Amen.
Amen.
Thanks, everybody. Thank you, everybody.
Yeah.
And